everyone joining us in this FIP webinar. Welcome to everyone in this FIP Hospital Pharmacy Section webinar. This webinar is titled Educating a Contemporary Hospital Pharmacy Workforce and Continuing Their Practice Competence in Developing Countries. So we're very happy that you're joining us today. I am your moderator, Marianne Ivey. Salwa Ehsan is joining us, as well as Dan Kabul and his colleague, Mr. Mubito. So we're going to move on and tell you what our program is. I'm the immediate past president of the FIP Hospital Pharmacy Section, and happy to be the moderator of today's webinar. We have a few announcements for you. This webinar is being recorded and live streamed via YouTube and the FIP events website, so we can see it again. The recording will be available on our website, www.events.fip.org. You may ask questions using the question box provided, and we will answer some questions at the end. You are welcome to provide feedback about the webinar to webinars@fip.org, and we hope that you will all become a member of FIP, again through the website, fip.org/membership_registration. So it's very important that members receive events like this, and so we would be very happy to have you as members. So again, I welcome you and would like to tell you the order of our program today. Dr. Dan Kabul will talk first about advancing hospital pharmacy in Namibia, curriculum transformation. He is the Associate Dean at the University of Namibia School of Pharmacy, and we're happy to have he and his colleague, Mr. Mubito, talk to us. Then we are going to have Dr. Salwa Ehsan, who's the Chief of Pharmacy at Shifa International Hospitals in Islamabad, Pakistan. She is going to talk about an application of the Basel statements on human resources training and development. So that's sort of an example of following and hiring an educated pharmacist, such as those pharmacists educated in Namibia, to her hospital, and how she's sure that they're competent once they begin practice in her hospital. When both panelists are done speaking, we'll have a discussion and time for questions from the audience. And then I will provide some wrap up and take home messages for you. So that is our program. The objectives are to address curricula of schools of pharmacy for pharmacy training, for education actually, and then ongoing continuing training to provide students and practitioners with the necessary knowledge and skills for contemporary hospital pharmacy services. Those are our learning objectives. And I'm going to turn it over now to Dr. Dan Kabul and Mr. Mubito, who are, again, Associate Dean and Director of Clinical Pharmacy, respectively, at the University of Namibia. So thank you both very much for joining us today, and I'll give the program to you, Dan.
Thank you very much, Marianne and FIP, for this opportunity to talk about hospital pharmacy in Namibia. So I'll be talking about how we are advancing hospital pharmacy in Namibia through transforming our curriculum together with my colleague, Mr. Mobita, who is the director for the clinical program. So let me just give a background of where the School of Namibia started. So Namibia is a country in Southern Africa, which gained independence just recently in 1990. So we are about 30 years of independence. The population is around 2.3 million people, as well as it's one of the countries with the highest income disparity. The rich and the poor are really found in this country, mainly due to the apartheid regime that also distorted the health system in the country. Therefore, at independence, the government of Namibia took it upon itself to strengthen the health system. And one way to do that is to have a health workforce. Thus, in 2010, there was a launch of the School of Medicine, as well as there were measures to start the pharmacy course. So we are just 10 years young. So together with support from USAID, a curriculum which was based on the needs of the country was developed, and the program for a bachelor's of pharmacy was implemented in 2011. Since then, in this curriculum, it's heavy on what we call placements or clinical rotations. So in 2012, that's when we started to implement clinical as well as hospital rotations for our students. In 2015, that's when we had our first graduates. So far we have graduated around 5. At the same time, we realized the need for technologists, pharmaceutical technologists to work with our pharmacists. So we launched a diploma in pharmacy at the same time. 2 years later, we also started a postgraduate program that is a master's in pharmacy that is clinical, to have a focus more on hospital pharmacy. As well, subsequently, we started our PhD program in clinical disciplines, and we have graduated a number of them since then. We are really glad that at this point, we are, after 10 years, we are reviewing our curriculum, and we had support from FIP as well as the University of Michigan to do an assessment of hospital pharmacy practice in Namibia. So we, at the moment, transforming our curriculum, and that's what I would like to share with you today. So that is the map of Namibia in Southern Africa, and the dots are indicating where our students do the learning. Our program is heavy on student placement throughout the country. It's not centralized within one region. The picture depicts our first cohort in the first row. Those are our first graduates, and we are hosting an antimicrobial resistance workshop, the first of its kind in Namibia. So through that, we have had interventions to strengthen hospital practice in Namibia. Among them is antimicrobial, as I've said. We have incorporated specific modules to strengthen these areas. As well as we have intentionally held workshops. We have taken the lead in the country to contribute to antimicrobial stewardship within the country, as well as develop specific modules or content for pre-service training. Again, we have set apart guidelines for developing countries on how to assess or implement rational use of medicines within a curriculum. So within the 10 years, we have made such strides. So you might ask, how have we decided now to change the curriculum? There are 4 reasons why we changed. Number one, as a University of Namibia, we are going through a restructuring. And that restructuring is mainly due to the need for education to be adapted to the 4th or 5th industrial revolution, which we call Education 4.0. It requires our learners to go through work-integrated learning, digital pharmacy or education, as well as it requires our learners to be innovative and creative. The other reason why we have decided to change our curriculum is because the government has changed the curriculum for high school leavers. And the high school leavers who will be coming to university will be holding an advanced subsidiary certificate rather than an ordinary one where we used to accept them that way. But more so, we have done a needs assessment together with the help of FIP. We have seen there are indeed gaps that we need to strengthen, particularly to do with hospital pharmacy practice. Could we have the next slide? So we are at the stage of a needs assessment. We have assessed, we have done a 360-degree assessment of what we need to respond to the different pharmaceutical needs in the country, and amongst them is hospital pharmacy practice. So these are highlights of our needs assessment. It was done in 8 of the 14 regions of Namibia. What I highlight in the red box is that generally our stakeholders are happy with our hospital and clinical pharmacy training. They are ready. All of them said either our students are excellent or they are good. 7 of them did not respond to the questions because they are not in that sector. However, they emphasize that we need to have a comprehensive hospital pharmacist, one who can be involved in clinical assessment of the patient, can do all aspects which are similar to a physician, such that they are easily integrated. Number 2, there was a need for collaborative practice. Once we did the hospital pharmacy assessment based on the Basel statement, we realized that pharmacists in Namibia are really centered on tier 1 services. So we want to advance tier 3 services within the hospital, but more so, we are transforming our curriculum such that it has a heavy clinical component, practical component rather than theory. So we'll have a balance of 80 to 20 practical compared to the theory in order to advance confidence among our students to take up tier 3 services. We also want to integrate digital pharmacy within not only hospital, but also other aspects of pharmacy. Then I'll hand over to my colleague, Mr. Mubita, who will take us through the other aspects.
All right, so I'm going to talk about the clinical program at the University of Namibia. So our curriculum has a focus towards training our students to be competent in the provision of pharmaceutical care. And since then, we have undertaken a number of efforts to see that this is realized. For example, we have looked at implementing clinical pharmacy within the undergraduate teaching here in Namibia. We've also looked at having to do some collaborations with a number of universities to come up with a postgraduate Master of Pharmacy in Clinical Pharmacy. Yeah. So as you can see from a number of papers published in the pharmacy education, we've been making strides in that area so that we have graduates who will be able to deliver care to our patients. Have the next slide, please. All right, so what this particular slide is showing us is as part of the 4th Industrial Revolution skills, which will be incorporated in every program at the University of Namibia and how they integrate into our program. So there are a number of unit standards or modules that each and every student at our university will need to undertake. And these include digital skills, ethics, leadership skills, citizenship, entrepreneurship, as well as primary health care. Our curriculum runs on a semester basis. So an academic year will comprise of semester 1 and semester 2, and it's a 4-year program. So here at the School of Pharmacy, we have decided that we are going to incorporate these particular unit standards across the 4 years of training. For example, in year 1, our students will be exposed to ethics and professionalism. Then they'll also be exposed to a module on citizenship. Really, this is meant to have graduates who appreciate their role as citizens of Namibia, or indeed many other countries where we get our students from. But largely also an appreciation that they are global citizens who can move from one setting to the other and be able to practice. Then what we didn't have in the past is a module on sociology and psychology. So as informed by the needs assessment which was done, in order to inculcate confidence in our graduates, we thought that our students will need some content on sociology and psychology, and this will help them in the care of the patients. Along with that, we also have these deliberate modules on leadership, so that when they graduate, these will be leaders in the healthcare settings, in the hospitals, and being able to really advocate for hospital pharmacy. So my colleague had alluded to the need for digital pharmacy, so that is also part of the curriculum, as well as entrepreneurship. So we want to have our graduates who will be able to, apart from being employable, but they will also be able to create opportunities for themselves and be able to employ others. All right, so in terms of our curriculum, our focus is on professional skills and how we are achieving that. I would like to share with you that in terms of the design of our curriculum, there are a number of legal requirements we need to meet as specified by our Pharmacy Act in terms of what the content should be. So on the far left, you'll see the Health Professions Council of Namibia requirements, where they need a Bachelor of Pharmacy curriculum to have about 86 credit hours in pharmaceutics. They need about 50 credits in pharmaceutical chemistry, 57 credits in pharmacy practice, 79 credits in pharmacology, and 43 credits in pharmacotherapy. So what you see in brackets, those are the approximate number of modules that we need to create, which will come to that. And I must mention that these are minimum requirements. So if you look through the proposed curriculum, I will focus now on the text which is highlighted in yellow. So this is how we want to prepare our students for hospital pharmacy, beginning as early as, I think what is indicated semester 3, under semester 3. We have Pharmacy Practice 1, which is a community placement. So already we are trying to get our students to be able to provide care in the community pharmacies way before they even come to the hospital. There they can have the opportunity to be competent and fluent in their communication skills, communicating to patients, communicating with the pharmacists in these areas. Then also, what we are looking at also is we had separate placements in rural settings as well as in the hospital setting. So we have integrated them into one. So this is where our students would go to a rural setting, a hospital, and be able to provide primary health care. So now we are going to have a combined module which will look at both the rural settings as well as the hospital placement. And this is introduced at a very early stage. Then there's also what we have got there is we have clinical rotations which will focus on infectious diseases and non-communicable diseases. So these rotations in the past were not under a module on its own, but now we are going to have a full module running for a full academic year. So students will rotate in infectious diseases. I think you can see in the picture, one of our students in the infectious diseases ward. Then what we have also done is that we want to align the clinical rotations with the theoretical teaching of pharmacotherapy and clinical pharmacy. So for example, in a particular semester 7, when the students are rotating in the infectious diseases rotation, they will be undertaking a module on clinical pharmacy and pharmacotherapy 1 with a focus on infectious diseases. In the following semester, they will undertake a clinical rotation in non-communicable diseases, and they will have theoretical teaching around the pharmacotherapy of non-communicable diseases. Then I also would like to mention that before we can actually get our students in their final year of studies to spend this 1 year in the hospitals, we would like to prepare them for the hospital setting by undertaking one other module, which is pharmacotherapy and clinical skills. And from the needs assessment, it came out that our stakeholders would like a graduate who's able to, for example, take part in immunizations. So these clinical skills will enable our graduates to be able to undertake a basic general physical examination of the patient, be able to, for example, administer medicines, administer vaccines. And we think this really will be able to contribute in the delivery of pharmaceutical care. Lastly, on this particular slide, I would like to also bring to your attention that in our curriculum, we have created slots where we have workplace integrated learning, and this is mostly in the afternoons. And we want to begin this as early as probably their first year of studies. Thank you very much. May I move to the next one? So apart from the professional skills, our curriculum also builds on a background of biomedical sciences. And just really to show again that our students are introduced to anatomy, physiology, and biochemistry. And what we are changing in the transformed curriculum is that these modules, anatomy, physiology, and biochemistry, will be aligned. So I would like to see a scenario where when our students are, for example, doing anatomy of the GIT, they are doing GIT physiology, they are doing a topic related to biochemistry of the GIT, which could be, for example, classes of our nutrients, proteins, amino acids, and those things. Then also we have a focus on pathophysiology and microbiology, which I think in this new transformed curriculum, we are going to place a lot of emphasis in the systems pathology, in bacteriology, virology, and parasitology. But also what is interesting in our curriculum is that we also offer some modules which are not really professional, but we want to introduce our students to pharmaceutical mathematics. So this is a module in mathematics which is really tailored to pharmacy. They're able to do pharmaceutical calculations and all applications in pharmacokinetics in this particular module. Now you may be asking, who are the faculty? So we have a multinational faculty from the region here, Zambia, South Africa, and also across Germany, Belgium, and a number of countries. And really, what has worked for us in our curriculum and in the new one is really this focus on collaboration. So in terms of faculty, we have visiting professors, some coming from the UK, the National Health Service. We have visiting professors coming from the University of Pittsburgh, from Idaho State University, and the University of Monash. So Monash has actually helped us with a dispensing tool called MyDispense, which we're able to simulate care in the community setting and handling of prescriptions as early as the first or second year of their studies. So part of the faculty also comes from colleagues with background in biomedical and pharmaceutical sciences. So a strong background in chemistry, biomedical sciences, and research. So in terms of full-time staff, we have clinical pharmacists, and these really are helping with the clinical rotations. We have clinical pharmacologists. We have a very good working relationship with physicians. And also, we are ideally placed in terms of our campus because we are nearby to 2 teaching hospitals. So we do rotations in those 2 hospitals. We have registered nurses as well. And not forgetting our stakeholders, the pharmacists working in these hospitals who have been very supportive and are willing to work as preceptors. We have community pharmacists also who are supporting our community placements as preceptors as well. All right. What degree does a student get when they train at the University of Namibia? And roughly how many graduates do we have? So just to show you, in that particular picture, again, this is a rotation in infectious diseases. This is in one of the TB wards where with patients with drug-susceptible TB and even drug-resistant TB. So our students are working individually under the guidance of a clinical instructor on a case that they will present later. So our undergraduates will graduate with a Bachelor of Pharmacy with honors. And we have so far introduced a Master's in Pharmacy and Clinical Pharmacy, and we have attracted 25 graduates. We are yet to graduate some of the students. As alluded to by my colleague, we also have already a PhD in clinical pharmacy, and would like to attract the graduates from these masters in pharmacy so that there's career progression. How has the curriculum changed pharmacy practice in Namibia? So from inception, what we have noted is that the local training of pharmacists in Namibia has really created positions in the varied scopes of practice. For example, we had a critical shortage of workforce in our hospitals, but this time most hospital pharmacies, the state and district hospitals have at least a pharmacist there, as well as pharmacists are also taking up roles in regulatory pharmacy. A number of our graduates are placed there and working also in policy within the Ministry of Health and Social Services. Then there are also a number of initiatives that we have undertaken. So we are currently running an anticoagulant clinic project where a pharmacist is part of the multidisciplinary team, and they're advising on warfarin dosing. Then also we've had a number of collaborations, especially in infectious diseases, mainly in management of HIV infection and TB, as well as we've undertaken a number of collaborative clinical research in that area. Then recently also, again, based on the needs assessment, we have just developed a curriculum for the authorized prescribing pharmacists. So one of the interesting things about Namibia is that the law had already provided for pharmaceutical care. So it is in black and white, as well as there is also a provision that pharmacists in Namibia can also prescribe. But there was no curriculum ready for that, which we have worked on. Then to support hospital pharmacy, we have an internship support program with a clinical focus. So during their pre-registration training, the university through its clinical instructors interacts with the interns or the pre-registration trainees. And I think also on this particular slide, you see this publication on an analysis of hospital pharmacy practices in Namibia based on the FIP's Basel statements, which brought out a number of issues that really will help us in advancing hospital pharmacy practice. Yes, so ultimately, what are the lessons that we have learned and that other countries would benefit from hospital pharmacy practice in Namibia? So having looked at our training up to this stage, we noted that really we need to have a 360-degree collaborative training program, which is interprofessional, bringing in different stakeholders, different healthcare professionals. Because ultimately, if we are going to produce hospital pharmacists working in the hospital, they will be part of a team. So even in the training, we bring on board these collaborations. Then to make the transition from undergraduate training into hospital pharmacy practice, we have deliberately placed emphasis on work integrated training. And our training is competence-based. So the focus is that our patients, our students attend competencies, for example, in patient consultation, in undertaking medication reviews, in making pharmaceutical interventions, in collecting medication histories, for example. Then our idea really is to train an all-rounded cadre who is able to participate from making assessment of the patients. Whether they find themselves in the community setting, they can make a physical assessment of the patient and decide whether they need to refer the patient to secondary health care or even tertiary health care. So not only focusing on dispensing, but really a continuum of care from assessment of the patient to dispensing, as well as patient education. Then in the digital skills module, we are also trying to introduce our students to an understanding of the health system, because care is provided within this context of the healthcare system, which we believe that our students should have this understanding and they should be well prepared before they get into the workplace. Now, the other lessons we've learned really is that there's need for mentorship. And one of our mantras is that we stand on the shoulders of giants. We are a relatively young school. We have benefited massively from our collaboration with our partners in the region, internationally as well, when it comes to aspects of, for example, looking for external examiners to ensure that there's quality in the education we are offering, having visiting professors from Pittsburgh, from the NHS, from Idaho University really helps us a lot. And we think that this platform today also will give birth to a number of new collaborations that we can have. So lastly, we think that we should think globally and act locally, so that there's a local context. And with all these collaborations, we can respond to our local needs. Thank you very much.
So thank you very much, Dr. Dan Kabul and Mr. Mobito, for a really wonderful presentation. I think that you are providing great leadership in pharmacy education. And it's clear from my work in international pharmacy that many schools of pharmacy could benefit from your model, because we know that there are schools of pharmacy in the world who still are pretty much focusing on chemistry and pharmacology and theoretics, as you mentioned, and not really preparing students for the practice site, whether it be in the community pharmacies or in hospital pharmacies. So congratulations, and we will take questions from the audience that are listening to this webinar later. But right now, I would like to move on to our next speaker, who is going to talk about how she hires pharmacists who are competent in her hospital, knowing that they have some of the basic education, such as Dean Kabul and Mr. Mobito talked about, although she's talking about a different country, Pakistan. So I'm very anxious to hear Dr. Salwa Ihsan's program. I think you will be too. So I turn the program over to her. Thank you.
Thank you very much, Marianne. And thank you, Dr. Dan, for an enlightening presentation. So obviously my presentation connects from where Dr. Dan left actually, because once the pharmacist graduates, they have to come to the hospital pharmacy for practicing. So what can be done in order to make sure that they get the best platform for, doing the pharmacy practice and actually helping out the patients in best pharmaceutical care that can be given. So I'm just connecting from there. So next slide, please. So I'll start with a brief introduction. I work in Shifa International Hospital as Chief of Pharmacy, and this is a 500-bed quaternary care teaching hospital. Just to give you an idea about the complexity or the acuity level of the patients that we manage, there are 4 transplant services that are going on in Shifa, and we have a very large critical care setup, including both pediatrics, neonates, and adult setting. This is a very busy teaching hospital site because we have affiliated school of pharmacy, nursing, medicine, and allied health. So all sorts of these students are coming in for their clinical exposures and hands-on practice. Shifa International is a Joint Commission International accredited organization. And next, I'll talk about briefly about the scope of services that Shifa Pharmacy offers. So we have a full decentralized system in which we have satellite pharmacies of inpatient, outpatient. We have emergency pharmacy. We have chemo and IV admixture program, and we also compound total parenteral nutrition in pharmacy. We also have sterile and non-sterile compounding section, drug and poison information center, and a very well-developed clinical pharmacy program. We also perform discharge patient counseling, and we provide a take-home service according to the discharge summaries. And we also run our JCIA accredited home care services in Pakistan. So what types of workforce or the types of pharmacists, grads or undergrads that we are dealing here at this practice site within our pharmacies? The first one is the undergraduate PharmD students that we are getting from our own affiliated school of pharmacy. Next is the internship program, which is a 6 weeks internship program that we run around the year. And we usually take 8 to 10 interns in every batch. And then we have 1 year residency program in hospital and clinical pharmacy, and they usually take 5 residents per year in this program. And then we have our own pharmacist, full-fledged on-the-job pharmacist, and they are 80 in number. So that's a huge number to manage, but you all would agree with me that managing such a wide, pharmacy workforce, both undergraduate and graduate pharmacists, it is impossible to let them do the patient care activities without inculcating the proper knowledge and skills. So if you equip them with proper knowledge and skills, obviously only then they will be better patient care providers. So when I say better, it means the safer care, more effective, more affordable, and more accessible. So that cannot be done without proper knowledge and skills. Next. So all my presentation, please keep these Basel statement number 58 and 59 in the perspective because it emphasizes on the workforce education, training, competency, size and capacity that has to be appropriate as per the scope of service, coverage and responsibilities of all cadres of providing pharmacy. So that's the first statement. The next is number 59. That also talks about that hospital pharmacy workforce plans should describe strategies for human resource education and training, recruitment, retention, competency development, and so on. So since this, the scope of my presentation is only to the capacity building, training, education, continuing education related activities, so I'll be confining myself to these points. Next is you should be talking about, you should be also looking at the FIP developmental goals, and in this there are almost 5-6 development goals which are directly alluding towards the academic excellence, the early career training strategies, or becoming pharmacist into specialized fields and advanced practices. Competency development and continuing professional education, etc. So on FIP website, you can find further details about how these development goals can be implemented in your setup. So since due to time constraint, I will not be going into much detail, but information is available on the FIP website. Next, please. So how we are doing in SHIFA. So first of all, keeping again the Basel Statement 58 and 59 into perspective, we first of all have a defined selection criteria, be it for job, if we are hiring a pharmacist, or we are hiring interns, or we are hiring for the residency program. We have a proper documented criteria for their entry. And sometimes we do take tests for formal assessment, for example, in case of residency program and in case of induction as a clinical pharmacist, the candidate have to clear the assessment test in order to be selected for the interview and to be finalized as a final selected candidate. The second important thing is that once you select good people, definitely based upon certain criteria, their baseline education and experience, it is important that once you put them into practice into different areas, for example, you are putting them into inpatient area, or you are putting them into compounding section, or anywhere else within your hospital, pharmacy. So there has to be some kind of a competency into that each area. So I'll just show you what types of competency components we have, but just to let you know that there is a defined checklist for competency into each area in which we assign our pharmacist into. And that is conducted at the baseline when the pharmacists join in order to assess what is their baseline competency and what are the areas of improvement. And then at this is repeated at the job confirmation time, which is usually 3 months time period, the probationary period. And the main points of these competency checklists are also embedded in their job description, so that they would exactly know that they will be performing these core tasks throughout their assignment into that area. And then we repeat it on an annual basis while we are doing the appraisals of our staff, so that we make sure the pharmacists are deputed in whatever section of the hospital pharmacy, they are continue to be competent in that area. And more so, most of the times when I talk to my colleagues, people do reassign or reallocate the pharmacists into different areas. Like pharmacists can be moved to outpatient pharmacy, for example. But if you are relocating your pharmacist, you have to do a competency assessment for that new area in which you are putting your pharmacist. So at the time of reassignment, yes. Then we have our proper staffing plan that we revise annually. And obviously, since we have a decentralized system, we have 20 plus outlets throughout the hospital. So it is really, a kind of a tricky job to manage the operations. So you have to see the average patient volumes or census, the peak times, the workload statistics of that area, what are the shifts that you're going to be managing, the counters you will be opening for the, especially for the outpatient pharmacies, what kind of a skill mix you require within the pharmacist, as well as the other cadres of the pharmacy staff like technicians, assistants, aides, what kind of a skill mix you require in a particular shift, and obviously the contingency plan. So contingency plan is coming big time, especially in times of COVID, when there were lots of lockdowns. The people were not available because of being quarantined, being infected with COVID. So there was a lot of scarcity of human resource at that time. So that contingency plan actually really helped us in maintaining a basic skeletal staff, and we were able to run our operations without any hindrances. Next, please. So this is just an example of the competency checklist. On the left side, you can see the compounding competency checklist. You can see entries regarding the laminar flow hoods, aseptic techniques, maybe spill kit management, maybe about some calculation skills. So these are built into the competency of that area. And on the right side, you can see the competency of the Drug and Poison Information Center pharmacist. So few things that those pharmacists need to know are the telephone etiquettes, for example, the communication skills, able to go through the primary, secondary, or tertiary drug information resources, and some clinical indicators that they need to perform. So this is embedded into that checklist, and this is done on a periodic basis, just like I've mentioned you, at the time of hiring, at the time of confirmation, and on yearly basis. Next, please. So I'll be talking about our 3 tiers, just like I mentioned before. First is the undergraduate. So these students which we are getting from our School of Pharmacy, and I'll also include the interns for the time being into this portion. By law, in order to avail the degree, in order to get the degree, there has to be a compulsory hospital pharmacy rotation. So these students are coming in at a defined time period within their 5 years degree program. So what we have done in order to enhance that exposure, because just like Dr. Dan alluded to the fact that more emphasis has to be placed on the practice side, not just on the theory. So first of all, we have done is that our practicing pharmacists within our hospital, they are appointed as adjunct faculty. So when they are teaching and mentoring and precepting these students, obviously they are giving more insight into the practice side of it. Secondly, the defined learning objectives are there, the proper assessments then done, and obviously the passing scores are there, so that minimum learning objectives are met before they move on to the next entry into the syllabus. Next, please. So these are some of the entries that we do. We allow them observership in all the areas of the hospital pharmacy, like clinical pharmacy, dispensing areas, inpatient, outpatient, emergency, etc. Preparation areas in which we have compounding, oncology, Ivey admixture. So all kinds of sections of the pharmacy. Then the practical exposure, for example, how you're counseling the patient, how you're doing the medication reconciliation, how you're interpreting prescriptions. So these kind of practical exposure. Then bedside teaching, classroom teaching on certain, defined topics. And then we have medical record-based review, like patient progress notes, patient history taking, patients, laboratory monitoring. So these kind of activities. And in addition to that, for those who have aptitude for hospital or clinical pharmacy, we offer them additional weeks of rotation during their summer and winter breaks. So these are voluntary things, nothing to do with their degree program, but this is an incentive that we offer for those students who have more attraction towards hospital or clinical pharmacy. So as a bonus scheme, we offer them the summer or winter internships as well. So this is the internship manual. Again, it's a 6 weeks kind of a rotation, but this is again a structured program. We don't leave them wandering around into the hospital or into the pharmacy premises just like that without any supervision. It's not the case. So they have a structured have to go through a structured program. Next, please. So I'll just show you this, one of the examples that our colleague developed in the ambulatory care pharmacy, the point of care at neurology clinic, where the pharmacists are doing medication reconciliation, adherence monitoring. So for example, if the intern is rotated in that area, what are the learning objectives he or she has to undergo, and what experience they can gain out of it. So that's already written and pre-documented. Next. So just to show you, this is the our website of our Shifa Tamir Millat University, and our adjunct faculty, which are our own practicing pharmacists, and they are overseeing the PharmD degree program as well as MPhil clinical pharmacy practice programs. Next, please. So next year is the postgraduate, that is 1 year residency program that our pharmacy offers. The first challenge that we were facing is the standardization, because initially we had our homegrown system, kind of a program, but later on we realized that unless we go for some international best practice model, it will be difficult for us to do in a structured and uniform manner throughout. So what we did, we adopted the ASHP, which is American Society of Health System Pharmacists, International Pharmacy Practice Residency Framework. So based upon that framework, some important perks that we get out of this standard system is that there is more emphasis on the learning objectives, because it has to be outcome-based learning. So the lots of emphasis is given on the learning objectives. They are predefined, and even the teaching material and resources from where we are going to teach or explain that learning objective is to be fulfilled, that is also predetermined. Secondly, the evaluation coming big time, because inter and intra rotations from section to section and two-way, like residents are doing the evaluation of their preceptors, and preceptors are doing the evaluations of their students or the residents. And it is action oriented, because whatever feedback we are getting out of the residents or the preceptors, that is discussed in the residency advisory committee, and the committee decides that what actions can be taken in order to improve the learning experience of our residents. And then we have individualized residence development plans. For example, 5 residents, 2 of them would be good in one area, but rest of the 3 might not be that much good. So what improvement we can further add in order to augment their learning experience within our organization. So that is an individualized resident development plan that we offer. The program is structured, documented with key performance indicators in order to monitor our own performance. The second challenge we had was the trainer. So the preceptors that we select, that is again based on the criteria, based upon their competency, skills, and experience. We have a proper eligibility checklist in order for any preceptor to be enrolled as a preceptor. So ongoing commitment for teaching, because this is something we do not pay them extra in order to become a preceptor, but this is something, an internal obligation that since I am a trainer and residents or students are coming towards our pharmacy, so this is our obligation, that professional responsibility, that we handle them properly and we inculcate all the knowledge and skills that is required at that particular level. So the preceptors are formally nominated, and then we have lots of emphasis on the competency development of the preceptors. So all the preceptors right now we are having, they are certified pharmacy preceptors, plus they have, we have developed their own development plan, because the trainer has to be, fully trained before he or she can impart the training. And obviously the preceptors evaluation that help us to further improve and fine tune the program. Next, please. So this is just the manual that we have, and you can see that it contains all the necessary elements of the residency program that I talked about. Next, please. So this is an example of learning objectives. So for example, this is a critical care pharmacy rotation. So you can see that what kind of, what is expected out of this rotation, what are the disease conditions and other topics that will be covered during this, what are the suggested reading material and sites from where these topics will be covered, what objectives will be met, and what are the activities that will be done in order to do to meet those objectives. So this is all predefined and documented. So nothing is in the air or in limbo that even preceptor and resident don't know that what is going to happen. So everything is documented and well structured. Next. So we truly believe that great leaders pull in future, not push. So the leaders are the preceptors and the practicing pharmacists. So unless we get them better, they are not going to develop the residents, interns, and undergrads in a better way. So we put a lot of emphasis on this particular thing, that they first need to be trained in a better manner. Next, please. So the last year is our pharmacist, obviously. So if there is inconsistent in undergraduate training or PharmD curriculum and lack of exposure during their PharmD training programs, degree programs, obviously there will be pharmacists with questionable competency, and they will not be ready for the practice. And obviously that puts a lot of strain on the in-house orientation and training. So what we do about this, next please. So in our setup, we have some mandatory topics and compulsory tests. I'll be talking about that in a minute. So we discuss and keep an eye on the outcome in terms of the pharmacist interventions as a result of prescription review, as a result of medication checking and filling, etc. The errors that are prevented. So that kind of an outcome assessment is actually linked with the training program. We offer simulation. So this is something that we started almost 6-7 months back. So this has really helped us in improving the quality of interventions and prescription review and the prevention of medication errors while we are dispensing medication. So we have developed real life examples of prescriptions and medications, and we have inbuilt error defined, put in some errors into that, which we already know, but the pharmacist who are going through that scenario doesn't know. So he or she has to pick and identify most of these errors. These kind of real-time simulations actually help them to identify what weakness they have during the review of prescriptions or during the filling or checking of the medications, and that really helped us a lot. This is something that we'll be repeating every 6 months. Then we have our monthly C sessions. We have satellite activity level daily huddles on different topics. Then we have sharing of important interventions in our groups. And last but not the least, this is something that we develop with the help of our management, that whoever does the Board of Pharmacy certification is eligible for a handsome monthly incentive in terms of some Pak rupees into their salary package. So this is a financial incentive in terms of getting board certified. So that is already, we have a couple of pharmacists already given their exams. So I'm very hopeful that this year, inshallah, will be getting some board certified pharmacists in Shifa as well. So these are some of the mandatory modules. We do it every quarter, and every pharmacist have to appear into those exams. And these are in-house developed modules. And this is one of our team, which is just recently taken picture a few days back, which is working on the current quarter's module on dyslipidemia and hypertension. Next, please. So few of them just the ones which were highlighted red, for example, medication management and use, for example, high alert medications. So these kind of modules that are must for every pharmacist to be well versed about these things. So we have converted these modules into a basic mandatory clinical competency for pharmacists. And whenever a new pharmacist joins, he has to or she has to complete that within probationary period. So unless they do it, they'll not get confirmed. So this kind of a basic competency is further into their, developed into their training modules. So that is something new that we have just started. Next, please. So we have lots of other things going on due to COVID. So we went virtual. Online C sessions, online tests, online recorded videos, and virtual conferences. So that was something that was done uninterruptedly even during COVID times. Next, please. Another important thing is that we are engaging outside experts, and this is an eminent pharmacist lecture series in which we engage experts from outside Shifa, and they speak about some important topics that are relevant to pharmacy. And this is something, another important training aspect for our workforce. Next, please. So another important thing is that access to drug information. So what we do is lots of sharing on the guidelines, infographics, alerts, and memos in terms, for example, if you see the next slide, please. Just quickly go through this slide, please. Safety alerts, look-alike and sound-alike drug alerts, addition to the formulary, one-pager information, guidelines on the COVID, dosing charts. Keep on, next slide, please. So the dosing charts, next. Pediatric dosing, quick guides, neonatal dosing charts. So lots of emphasis on the drug information part of it, because this is something that enables a pharmacist to act in a better way. So if they have this access and they are knowledgeable about certain drugs and their important safety aspects, only then can there be, preventing the mishaps and providing the best pharmaceutical care. Next, please. So we have newsletters, we have our antimicrobial stewardship bulletins, we have our pocket guidelines available. So just to aid further their learning. And we have patient information brochures, and we have, counseling checks for high alert medication, so that every pharmacist performs that in a uniform manner. So there should not be a variation between the newcomer and the one who is been in Shifa from last 10 years. So no variation, so everybody follows the same checklist. Next, please. So all this information, because lots of memos and guidelines and alerts are being generated every month. So all is accessible on the intranet website so that everybody can access it on just one click. Next, please. And last but not the least, this is my last slide. We put a lot of emphasis on the training and capacity building of our staff. And I'm proud to say that Shifa Management is our partner into this. On the first picture, you can see at the right, 3 of our pharmacists completed certification, which was funded by Shifa International. One was in antibiotic stewardship, one was an anticoagulation certified pharmacist, another one was a certified pharmacist in compounding sterile preparations. So these 3 certifications were funded by Shifa, and you can see the Chief Operating Officer, the Chairman of Pharmacy and Therapeutics Committee, and myself and my colleagues. We are actually celebrating this moment because we put a lot of emphasis that this workforce needs to be properly trained in order to serve better. And we recognize them and we reward them and we try to motivate other staff members as well, because the learning, kind of culture has to be, promoted. Next, please. So in the last, I'll just conclude my presentation by saying that I truly believe and I truly try to practice that pharmacy is a knowledge-based profession, and without inculcating all these knowledge and skills and keeping abreast of the latest developments, you cannot serve your patients better. Thank you so much.
Thank you so much, Salwa. It is really clear that you are providing really wonderful leadership to Shifa International Hospital Pharmacy Department. The program that you just talked about is really very sophisticated, and it shows a great collaboration really between the practice of hospital pharmacy and what colleges of pharmacy do, and shows what can be done and what more can be done. We are running a little short of time, but there are a couple questions which I'd like to take. One came from Nora Gerpe, and she is asking, and I think this one is for Dan, is the pharmacy school accessible to the population in your country? In other words, I think she's asking if the faculty members can give talks within the country. So Dan or Dr. Movita, if you're still on, would you mind answering that question?
Thank you very much, Marianne, and the person who posed the question. Yes, the school is very accessible. Remember, it's a national program, so like we highlighted, we are open to collaborations if there are presentations to work with. Yes, we're open. If I got the question correctly. Marianne, was that, did we get the question?
Yeah, I think so. Do the faculty make themselves available to say community pharmacies or associations within your country to be speakers?
Absolutely. What we said, our training model is really collaborative and not necessarily through webinars like this one, but they are part of our sort of staff, or some of our part-time staff are actually people of the pharmaceutical society. We intentionally include them. They are working with the hospitals, they are working with the medicine regulatory organizations. They are part of the Health Professional Council. So yes, but also every year we organize a conference with the society, which we host at our university, at the school. In the last year we were unable because of the pandemic, but yes, the school is very accessible. Thank you.
Thank you, Dan. And Salwa, one of the things that you clearly outlined was how your pharmacy staff at your hospital become faculty, adjunct faculty at your Associated School of Pharmacy. And did this take a long time to do? This is a wonderful activity because it brings the expertise of practice into the classroom for students to hear about directly. Did that take a long time to do, or how did you do that?
Well, luckily in our case, we have a very good rapport and collaboration with our Dean of School of Pharmacy. And he himself is a very big advocate of this, this concept that the practicing pharmacists should be highly engaged in the training of and the education of the pharmacy students. So luckily in our case, didn't take much time.
Okay, well, that's great. And I think all pharmacy practice sites and schools should try to emulate your collaborative model. The last question is also for you, Salwa, and that is, do you have a collaborative practice agreement in your institution with your physicians where your pharmacists can directly manage patients?
Well, actually, not in the form of documented MOU, but definitely Pharmacy and Therapeutics Committee is the apex committee of the hospital that mandates pharmacists that they can, they are charged with the responsibility of reviewing the prescriptions, identifying drug-related problems, helping physicians in optimizing the therapy, counseling patients, doing the reconciliations, and many other things that is included in the scope of pharmacy. And second important thing is that was not very easy task, because a few years back when this hospital was not Joint Commission accredited, so we really had a hard time convincing our physicians that this is the job of pharmacist, and we are here to help you actually. So the Joint Commission accreditation actually helped us, because the standards are defined in such a manner that actually mandates you directly that this is the part that should be taken care by the pharmacist, and this is something that the pharmacist is responsible for. So by standard approach plus some kind of a rigorous discussion and rigorous engagement of pharmacists with physicians, we were able to change their mindset. Marianne, your mic is mute.
Thank you, Salwa. And that question came from Richard. So we thank you for the question and Salwa for the answer. And we appreciate that the details. I would like to move on to our final slides and announcements because we are out of time. Reminding everyone that there is a lively discussion on Twitter about universal health coverage through pharmacy with the FIP CEO, Dr. Catherine Duggan. So encourage you to listen to that. And next slide, please. So you can check on all FIP digital events by going to events.fip.org. I think this was an example of a really fabulous presentation from both Dr. Dan and Mr. Mabito and Dr. Salwa Ehsan. Really amazing information from both of them that could be replicated by many hospitals and many schools of pharmacy around the world. So I'm going to sign off, thanking again the speakers and FIP and you for attending. Thank you and have a great rest of the day.
Thank you.